touch is a very loaded gesture. So touch reinforces hierarchies, it also dissolves hierarchies. And any literature on caste, on untouchability, talks about how untouchability is a very ideological and political tool to kind of maintain and reinforce caste hierarchies. I am Panchali. I work as a research consultant with various organizations, and I mostly focus on labor, livelihood, migration from a gender perspective. My book, Politics of Precarity, Gendered Subjects and the Healthcare Industry in Contemporary Kolkata, looks at how caste and gender intersects with labor. And what I do in this book is I examine how different groups of women work in an overwhelmingly feminine service and how one group is pitted against the other. So I was actually trying to see how gender and caste works within the nursing occupation to produce that kind of a workforce that is divided by gender, caste, class, sexuality. Nursing is located in the cusp of two very contradictory trends. One is, of course, the tremendous social and economic mobility that it offers to women trained in nursing with international migration. And the other is that nursing is still considered a very caste-based labor. There's a lot of stigma associated with nursing. So how do these two very contradictory trends inform each other? And how do women experience care work? And that is what led me to explore nursing. I knew the kind of stigma that is associated with the labor, but I was completely taken aback by the caste discrimination that existed within the profession. How women spoke about that, they were treated as untouchables, they were treated as dirt just because they did labor that included body care. That for me was a big revelation, and that for me changed the whole perspective towards the way I approached the research. I had done a lot of reading on care work, and I must say that it was a lot from Western feminism that, the understanding of care work and understanding of caring labor. But when I went to the field, I realized that for Dalit women, labor was not a source of joy. It was drudgery, it was humiliation. So humiliation became an important point in my research. Humiliation was a central emotion that women were undergoing, and how humiliation actually, so to understand how subjectivities are produced and what does public humiliation do to a worker, how does the worker then not have any self-worth? How does, a subject is produced who's bereft of joy because the work that they do sometimes runs the family. A lot of women are also single parents, single women who are running the family with their meager earnings. But the humiliation that they undergo in the hospitals take away that joy from their lives. So labor is no more a source of joy, but a source of humiliation. So I was very intrigued with the colonial roots of nursing, and I started going to the archives. So the first thing that I was greeted with in the archives was the fact that there were no records, very few records on nursing. So most of it focused on either women doctors, or the Dai. We have no pre-colonial records of who the nurse was. And the first mention of the nurse is when the British Army started, the European officers started asking for better medical health care. So nurses were brought from England to kind of train women in nursing, to offer nursing care to the army. And that is where nursing actually took off. But if we explore a little bit more, we would see that it was just not the army, but there were various forces that started playing in women's health. One was, of course, the white woman's burden, where evangelist efforts, as well as women who graduated in medical education in England, but were not being able to practice because of their patriarchy, migrated to the colonies to practice medicine. So a lot of these factors started playing to bring in women's health into focus, and the role of the women doctor and simultaneously women nurses. But women doctors and nurses found the Dai as like somebody who stood on their way. So the Dai was a very central figure in Indian women's lives. So she was also very marginal in the indigenous healthcare system. She came from a lower caste families, but she was also very integral to the rural village life. Indian women did not want to go to the colonial doctor or to the colonial nurse, and so the Dai had to be removed. And very soon a nationalist discourse started emerging, where the Dai was labeled as primitive, as barbaric, as a symptom of India's lack of progress. And there was this call to remove her, to eliminate her, and to let Western colonial medicine, headed by the doctor and partly by the nurse, to kind of take over. And there's this myth that that indigenous healthcare system and Western colonial medicine were in conflict with each other, and they were completely two disparate systems. That was not there. They learned from each other, they took from each other. So even if the figure of the Dai was being marginalized, her knowledge and practice was being incorporated in Western obstetrics and gynecology. And we have archival records of that. During colonial period, there was also a big push towards understanding service, understanding social work, understanding nation building, where you had people like Swami Vivekananda or Sister Nivedita, who were saying that service to the nation means service to the people, which is why Swami Vivekananda would go with his disciples and serve patients of plague and would physically give bodily care. But as long as this service was seen as a service that is social work, it was elevated, it was part of spiritual femininity. But the minute this service was brought into the market as a nurse, it got stigmatized. So it's like if you take money for taking care of somebody, it's almost that you've lost that the sacrificing, the spiritual aspect of that service. So nursing continued to remain stigmatized despite this whole push towards nation building and service to the poor, service to the ill. It did not really touch nursing, and it continued to struggle with this notion of a caste-based labor, a notion of stigma that were kept associated with it, which continued during post-colonial period. Indian women were ready to train in becoming a doctor, but they were not willing to train as nurses because of caste-based division of labor. So being a nurse or being a Dai meant that you had to deal with the body, its effluence, its detritus, and this Indian women, caste women, were not keen to do so. So even European nurses who started coming to India shied away from this kind of a work because they said that, we are being labeled as the Pankha Kuli woman, which is the lower caste, menial, plebeian woman. And even Florence Nightingale, when she was writing on India, said that, we have to create a new category because in India, because of the caste system, upper caste women will not train to be nurses if they are going to be asked to do menial labor. So a whole category started emerging, which even after independence continued, which was the nurse-Dai, which is the Dai given some basic instruction on Western colonial medicine, brought into the hospital system as an attendant to the nurse, which has now been inherited by our attendants, our nursing ancillary workers, the attendants. So how does a nurse then become a medical worker is by distancing herself from manual menial labor. But nursing includes manual menial labor, and who is going to do it? So the notion of the category of the nursing attendant, the maternity attendant, the private sister, the nursing ancillary worker started emerging, which was mostly Dalit women, working class women, rural women who entered the profession as almost like an invisible layer who gave hands-on care. So how does a nurse then distinguish herself from the ancillary nursing staff? By insisting that her work is nothing more than administrative, supervisory, or medical, and leave all the manual menial labor to the nursing attendant. And there's a lot of contest about who does what work, and caste then becomes a central constitutive factor in making sure that one workforce is pitted against the other. So the question of caste really came up to me is when women started narrating about practices of untouchability. So one of the most commonly used term to describe this work by attendants and ancillary nursing workers was dirty. what in Bangla what we say nongra. So they would say this is dirty work. How can this work have any respect? It deals with the body. It deals with bodily detritus, its effluents. So doctors and nurses treat us like dirt because we do dirty work. So that kind of alerted to me how deeply casteist notion of labor is embedded in their experience of laboring as nursing attendants. So when I would ask them that, does it play out? What do you mean when you say they treat you like dirt? They would say, so they don't share space with us. They will not enter the same lift with us. In fact, we have different lifts. So even the hospitals and nursing homes have these kind of spatial arrangements where doctors and nurses use a different lift and nursing attendants and maternity assistants use a different lift. And they've said even when they ask for a pen, they will ask us to wash our hands, or they will, not directly. So in the private hospital, the nurses went up in arms saying that we will not eat. Why will we dine with attendants in the same table? So these kind of casteist practice of untouchability, of spatial rearrangements were very evident in the hospitals and nursing homes. But the only time, and this even the nursing teachers and the leaders tell me, is that the only time the government nurses came together to strike was when they insisted that this private sister cannot wear the white uniform of the nurse because it is an affront to the nursing ethos, the nursing ethics, that the only woman who can wear the nursing cap and the white nursing uniform is someone who has formal nursing training. So they did not say that remove them, because if they were removed, then the manual menial care have to be given by the trained nurse. All they said is make sure that they are not confused with the trained nurse. So give them a different colored sari as a uniform. And this is one of the core arguments of my book, is this politics of distancing that creates a differentiated workforce. That how does a middle class, upper caste trained nurse distance herself from a working class Dalit nursing attendant? By what markers? The uniform is one of the major markers. Romances at workplace, intimacies at workplace happens everywhere. But how is it projected? So for instance, there's a huge class difference between doctors and nurses and attendants, right? So there's a lot of anxiety about caste class transgressions that happens when there's in the healthcare sector, where there's people from all kinds of caste, class and communities working together. For me, it was very interesting how these romances were projected. So when the nurse spoke about relationships, so one is of course the popular images that are shown, the popular cinemas that are shown, and I would like to talk about one, which is Pratidwandi by Satyajit Ray, which is an extremely famous film where there is this character of nurse who is played by a cabaret dancer, bar dancer, Miss Shefali, where she's projected as a sex worker, as someone who doesn't care for her patients, and who's literally, and who's symptomatic of the city's decline, of its cultural and moral decline. And this, I think, has a lot to do with the anxiety of women's employment. And very interestingly, I was narrated the incident when a group of nurses went to the director and said that you have to change the scene. And so for me, it was very interesting that they said, don't delete the scene. They didn't ask the scene be deleted. They said that the labels in the nurse's uniform, which signified that she's a trained nurse in a government employment, those scenes showing the labels have to be removed. So what they were doing is a politics of distancing, that you can show nursing attendants, untrained nurses as sex workers, we are okay with it, as long as you don't project middle class trained nurses as sex workers. So it's a lot more complex and complicated. So coming back to how this kind of a class caste, how it constitutes notions of romantic alliances, is that when a nurse talks about relationships, the workplace relationships, it's always with a better off patient or a better off doctor, which ends in either marriage, which then all transgression is forgiven, or it ends in a betrayal where the male patient or doctor has betrayed the nurse. So it ends in a victimhood. And for me, it was very interesting because both denied sexual agency to the woman. And I felt, and I've written about it, that this was a marker of respectability. The fact that the nurse is not a sexual agent. And when it came to describing romantic alliances or relationships of working class Dalit women working as attendants, it was always of promiscuity and sex work, that as if she was oversexed. There was an over-sexualization. So nurses narrated incidents of, oh, you step out of the hospital at night when when you're coming to interview us, when you enter, you will see women standing in the street soliciting customers, and these are our nursing attendants, and they give nursing a bad name because the public cannot differentiate between an untrained nursing attendant and a trained middle class nurse, and we all get stigmatized because of them. So the stigma that nursing faces due to the allegations of promiscuity and sex work is then, by the nurse, she distances herself from that allegation by blaming it on the working class nursing attendant. I think that the COVID-19, the pandemic, kind of brought to the forefront the crisis within the healthcare sector. And one of the ways of the state responding to this crisis was to glorify it, is so that calling doctors, nurses, cleaners as COVID warriors was to deflect attention from the fact that a lot of these working class Dalit workers in the healthcare system, at the bottom end of the healthcare system, who are in the forefront of this response to the COVID, are in precarious employment. They have no job security. They can be fired anytime. They're paid lesser than minimum wages. This is what should have come up during this epidemic. But what instead was done is to put them up in a pedestal so that no question can be asked. And I think what we needed was a language of rights, a language of justice, not a language of glorification and compassion. And the whole idea of a COVID warrior, or this war, the epidemic as a war, is something that is deeply problematic, because who are at the forefront of this response to the epidemic? Mostly women, the ASHA worker, the Anganwadi worker, the nurse, and the one category that we do not talk about, the nursing attendant, the private sister who stays 24 hours with the patient in the cabin. In the statistics, if you look at the government statistics and if you look at the death statistics, they're giving statistics of the doctor, the nurse, the ASHA, and the Anganwadi worker. They are not looking at the category of the private sister, because a lot of times the private sister is not even enrolled as an employee of the hospital. Projecting this response to the pandemic as a war is to masculinize it, invisibilize the feminine caregiving. That is the main response to the disease, to the pandemic.